Dear colleagues, this is phacoemulsification of a cataract with shallow anterior chamber and a bit of vitreous upthrust. By this time, the main incision 2.8 mm and two sideport incisions, each 1.4 mm, has been made. Now, capsulorhexis is being done. I incise the capsule with a 26 gauge bent needle, raise a nice flap like this, which I can hold at on go. Here it is. I use this Utata forceps, hold this flap, and when the cataract appears a bit hard, grade 3 plus or grade 4 or above, I aim for a large rhexis like this. So this is about a 6 millimeter rhexis, and here it is. Hydrodissection is to be done very gently. I take a 27 gauge cannula and BSS to do hydrodissection. The fluid wave is passed underneath the anterior capsular rim, goes to the opposite equator. The nucleus is gently tapped so that the fluid comes anteriorly along the equator. The nucleus rotates nicely, and now the case is ready for introduction of phaco handpiece. Viscoelastic substance is injected. I use ASP-MC, that is hydroxypropyl methyl cellulose. And now the machine being used in this case is Oatley Cataracts 3 phaco machine. Since this is a cataract of moderate density, a little bit on the harder side, here it is how I do it. I'm going to try direct chop in this case. I impale the nucleus, the tip goes into the substance of the nucleus like this, and this is vertical chop. The chop, the crack travels antero-posteriorly, and this is vertical chop. Nice crack has occurred in this case, and the nucleus has been divided into 4 fragments. Now each fragment is healed with vacuum and it is emulsified and removed. Phaco power used in this case was 70%. Flow rate is 45 ml per minute and vacuum is 450 millimeter of mercury. In this case, the crack is good, but still some posterior plate is there. So I am going from periphery to center. I am trimming nucleus. Now here it is how I manage the posterior plate. I'm trying to tilt it. Yes, I have been able to tilt the posterior plate, and the posterior plate is conquered in this way. Now here it is, this last fragment. See what happens. Whenever I'm trying to emulsify this, I can see the antechamber becomes shallow, and there is a thin layer of epinucleus, and what I do is I come out. I didn't take chance to emulsify it and at the same time cause posterior capsular rent. So I injected viscoelastic substance. Now I go into the anterior chamber, go underneath this rim, and again I see that I'm not able to do it. So I don't take chance again. I come out. I will inject more viscoelastic substance and I will see to it that the posterior capsule goes far backward. Yes, a large amount of viscoelastic substance has been injected this time. The idea is to emulsify this last piece before the anterior chamber becomes shallow and the posterior capsule comes forward. So here it is. I didn't use the side port this time, and I just removed the last fragment and I came out. That's it. The nucleus has been removed, but there is a very small bit of nucleus for which I will not use this one. I will not use the handpiece. I will guide this piece to come out like this with the Simcoe. That's it. We can do it with the irrigating probe of bimanual also. It will just to escort the last bit of nucleus to come out of the anterior chamber. Now this is the removal of cortical matter. I'm using a Simcoe cannula. These side ports are 1.4 millimeter, a little larger. Usually the side ports are 1 millimeter in case of bimanual IA, and this is about 1.4 or 1.5 millimeter. Now the cortical cleanup is nicely done, and that's it. Now in this case I use HPMC. The antichamber was shallow in this case, so I'm using HPMC and a hydrophobic acrylic intraocular lens, and the lens is being implanted in the capsular bag. Here it is. The lens is injected, the leading haptic goes into the capsular bag, the chopper guides the trailing haptic to go into the capsular bag. That's it. And now this viscoelastic substance is thoroughly cleaned out. I clean a portion of this viscoelastic substance first by Simcoe cannula, and then I take this irrigating probe of bimanual IA and remove the viscoelastic substance from behind the lens. This is very important. To remove the viscoelastic substance that has filled up the capsular bag, all those viscoelastic substance must come out. Irrigate thoroughly. Then I use irrigation and aspiration both, and I make it sure that thorough cleanup of viscoelastic substance has been done. And now this is moxifloxacin. Now the side ports are hydrated. The stromal hydration at the site of side ports are done. The lips of the side port oppose tightly because of this stromal hydration, and a final wash is given at this time. Unless I give this final lavage of anterior chamber, I don't feel good. I remove everything, even moxifloxacin that I have used. I just flush it out, and fresh basis is allowed to remain in the anterior chamber. The anterior chamber is formed nicely with BSS, and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your skills, and I want you to be a good surgeon. Thank you for your attention.